Good afternoon and welcome to the MIDAT conference. And today I am going to try to go over the way we attempt doing interventional radiology here at LSU. And we're going to go a little fast because tomorrow we have an in-service simulation with ultrasound, and it's going to be at 7:30 in the simulation lab, and that could be kind of an interesting thing. So, you always need to tell your conflict of interest, for you're not familiar, but that's an important thing as a formality, and I'm consultant for Boston Scientific. So, this is going to be an introduction for the interventional radiology for this year. And interventional radiology is a contact sport. It's a contact sport for the patient, the residents, and the faculty. I don't know which we want to choose here. This looks like the patient, and this looks like the faculty and the resident. But has an anxious touch. The patients usually don't get broken. They do okay and minimal trauma. So these are the players of the year, the new players that we have this year in alphabetical order. Daniel, Aya, Luis, and Carson. They are doing very good, and actually I'm very surprised how good they adapt and thrive with the first experience with interventional radiology in our department. So the learning objectives of what we're going to speak today, this morning, is to describe the principles of image-guided intervention in our place, to review the evolution of invasive treatments, and to learn on current trends of image-guided minimal invasive interventions. Well, the term interventional radiology was coined in 1967 by Alexander Margulis, which at that time was the chair of radiology at UCSF, University of California, San Francisco. And since then on, it was called interventional radiology. So interventional radiology now is 48 years old. It's a nice age, experience, maturity. And the history and evolution goes that imaging modalities initially used for diagnosis are utilized to guide safe insertion of needles and catheters practically any place in the body. And new materials are developed to broaden the indication of these techniques. And you see that constantly. Last week we did thrombectomy, putting a little vacuum within the pulmonary artery for a patient with pulmonary embolism. So the definition from the Society of Interventional Radiology, which encompasses the interventional radiology in the US, is the medical specialty devoted to advancing patient care through the innovative integration of clinical and imaging-based diagnosis and minimal invasive therapy. The goal, to achieve diagnosis and therapy with minimal trauma to the patient. There are two main branches. One is vascular, which is single system-based imaging modalities and techniques, and non-vascular, which involves multiple system-based techniques. Both require skills. Skills are image expertise, clinical knowledge, and technical proficiency. Without any of these three, it cannot be practiced safely. The paradigm today is that the patient that comes here has a pre-procedure evaluation preparation, a procedure performance, post-procedure follow-up, and evaluation of results. This is the integral management of the patient. It's not just doing the case and forget about it. So at LSU, it's a clinically based interventional radiology. We do daily rounds, we perform the cases, we have an outpatient clinic too, actually, one interventional oncology, and meeting privileges for a short time, and interaction with other specialties. And sometimes we do anti-gravitational rounds. This is a few years ago. Manoush Kerkar, remember him? He's doing very well in Dallas. So the process has 3 stages: the pre-procedure, where you evaluate and prepare the patients, perform the procedure is the second one that follows, and post-procedure is the follow-up. And at LSU, the pre-procedure can be according with the patient location in an outpatient basis or inpatient basis. A patient can be clinical direct if it's can be directly referred for a procedure. Depending if they are prepped in another place, we don't need to delay the admission. If it's an inpatient in the ward and do the procedure, and after the procedure they may go home or be admitted. And then the follow-up is done at the clinic, long-term follow-up. So in a way of summarizing our actions here, we have some guidelines, which is a decalogue. And decalogue comes from Latin, 10, and logos, enunciate or statement. And the decalogue is availability, rapport with patient, rapport with physician, imaging expertise, clinical knowledge, image-guided selection, anesthesia selection, technical proficiency, follow-up, and continuous evaluation and improvement. And for the old residents, this is something old that you have seen repeated. I know you have it glued in your head, but for the new players that are coming to the field, it's important to understand and put together how we work. Availability is always available, 24 hours a day, 7 days a week, and especially on weekends and holidays. Rapport with patient and family. That's an initial patient contact. We explain the condition and alternative treatment options, review benefits, potential risks, and complications of the procedure, and make sure that everybody understands, especially when we are dealing with people that are not very well educated and or aged, especially in children. Remember always to talk to the parents and make sure that everybody is in the same page. Rapport with physicians, communication before patient contact, discuss the plan, and assume full responsibility. Okay, I rather prefer us to prescribe antibiotics that says, tell them, give me an antibiotic that you like or a broad spectrum or whatever. We are physicians, and in order to gain, I would say, more a bigger role in the management of the patient, we really need to assume responsibility. Imaging expertise is key. We need to have familiarity with imaging methods for diagnosis and for guidance strategy. You need to be familiar with multimodality imaging, fluoroscopy, ultrasound, endocavitary, CT and MRI, and sometimes endoscopy. Clinical knowledge is key, especially to understand what's going on after we work. To find clinical and imaging finding correlation, and treat the patient, not the images. Image-guided selection, it depends on availability of imaging methods. It's good to avoid radiation as much as possible. Sometimes the choice of image guidance depends on an interventionist preference. Some people like more CT than ultrasound. Some people, prefer something else. And cost is also important. Remember the simplest thing, the least costly is ultrasound. The most costly by far will be MRI, but we don't do any interventional radiology guided by MRI. So non-vascular interventions, let me go back one. Vascular interventions, the image guidance is fluoroscopy 90% of the times and ultrasound 10%, usually for access. In non-vascular interventions, image guidance is ultrasound 70%, fluoroscopy 50% combined with ultrasound, CT 30%, also combined with ultrasound. That's why ultrasound is so prevalent. And MRI, in the time I've been here, we have never used MRI for guidance, which requires specific equipment for safety and also specific materials to work with. Anesthesia selection, we use procedural sedation for most of the procedures, general anesthesia for tips, radiofrequency ablation, microwave ablations, irreversible electroporation, and also for uncooperative frail patients that may require intravenous propofol or spatial sedation. Technical proficiency. Access is key, especially for the non-vascular or even the vascular. You cannot get into the artery, you cannot do an angiogram. The multimodality familiarity is important, and the hand skills, eye-hand screen coordination. In vascular intervention, the axis for arterial, the groin, is about 90% of the times. Others could be brachial, the radial, or translumbar. And venous, diverse, base of the neck, groins, extremities, or PICC lines. Non-vascular intervention, the axis is variable depending on where you're going to be working, in the thorax or the abdomen. Transorificial, transrectal, vaginal, or stomal. A colostomy can be a route that you can like to get to do a procedure. And musculoskeletal. This is a friend of mine, Dr. De Gregorio, who's a fellow, Circe fellow, and came here for a sabbatical, that when his group were the initiators of the transanal colonic stent for malignant colonic obstruction, and he's working with the combined endoscopy, fluoroscopy guided transanal colonic stent placement. Here you see the endoscope. This is the sigmoid colon, and here you can see the apple core of the tumor. Okay, past the wire, and this is the stent have been placed and looked after. I think it's important. It helps with time and efficiency. The maneuvers for IR are simple. We push, we pull, we angle, and rotate. And these maneuvers, are simple and they are not complex, so that they are hand skills replacement. And this is in December 1999, where we did the first robot-guided biopsy with a very old robot. Look at the robot today, which, so this is Justin. This is the agar with thymol. It's just a colorant for giving a little more appeal, And this is these are manzanilla olives, the needle and the target. But robots, the word robots comes from the Czech robota, which means forced labor. Karel Čapek was cited that in 1920. Karel Čapek is a writer. By 1997, National Geographic said that there were 350,000 robots at work worldwide. And today, all the factories that make cars and many other kind of equipment and machines use robots, have interesting names. Aesop and Zeus were the beginning. Da Vinci is the one that you can see here, which is the one that is used in the hospital and for thoracic and abdominal interventions, also ENT and so forth. And robots have gained a lot of popularity, because of dependability and, allow the surgeon to be a little more comfortable. These are robots for percutaneous procedures. So in robotic endovascular procedures, you have seen here, some of you that have been before, the Magellan, and this is the Magellan. We were in the process of trying to acquire one, but political issues have made this a little cloudy. We do not know what's going to happen. And this is a group from El Paso that got used it. We are ready to use it. We want to use it, but don't know if we're going to get it. Follow-up. Immediate post-procedure and during hospitalization, and long-term follow-up at the outpatient clinic. Immediate post-procedure, epic brief operation note, post-op orders, catheter management, pain meds, antibiotic, lab work, and nutrition. This needs to be done before the patient leaves the room, immediately. And notify the referring team of procedure outcome and plan. Remember, the 5. I don't know if you remember, Megna, but there are 5 things you need to say. Okay? Who, how, whom, date, and time. So it's an important thing. And then the risk packs procedure reports, that you need to dictate. We have some kind of templates, but I think we need to work on that a little more, especially because of the importance they have with the issue of charging and coding the procedures. So, in a nutshell, the vascular interventions, the effort energy needed is patient evaluated 20%, procedure performance 70%, is most of the work you're going to do in vascular procedures happens in the room, and the follow-up 10%, more or less. and then you will follow at the clinic. But in reality, in general, the vascular procedure require most of the attention and most of the effort at the time of the procedure. Non-vascular, the effort and energy needed, patient evaluation the same as the vascular. You need to know who you're working with. And the procedure is about 50%, but the follow-up is as important as the procedure. If you put a catheter and abandon it, probably your results are not going to be very good. Fortunately, patients do well, and nature is wonderful, and a little help of a catheter, makes those people get well, I would say, at least 50% of the time. But if you work with a catheter, your success rate is going to be 80 or over 90%. So the immediate follow-up is immediate post-procedure, and long-term follow-up at the patient clinic. Here, this is a post-procedure doing the irrigation, making there are no residual fluid, and we can talk more about that when we talk about drainages. The long-term follow-up is at the clinic. This is the old clinic. This is Juan, and Juan now is at in the West Coast, in Monterrey. This is one of our pancreatitis patients and one former nurse. Okay, this patient did great, went home with the catheters at gumbo and came back. We rescued her, they did well finally. And their clinic can be very busy. This is Travis Henley, and now he's an interventional radiologist in Willis-Knighton. These are all people. And what does this patient have? This is a patient that was kicked by a horse and fractured the pancreas in half. Boom. And we managed percutaneously. Had a fistula, we controlled the fistula, the patient did well at that. When he was coming here, we noticed something in his nose. And we sent it to the dermatologist because what do we thought about? Basal cell. Okay, correct. This is a basal cell carcinoma. So imagine the people were very surprised but obviously, that's why it differentiates a technician from a physician. You really need to see the whole patient. So continuous evaluation, improvement, analysis of process and results, education, research, and update through publications, courses, and meetings. And we do that. We do that locally, nationally, and internationally. The residents are encouraged to do case preparation and presentation at these conferences, radiology pathology conference that you regularly do, and I'm thankful over that. I'm so happy. And participation in projects, in posters, afters, and papers. And invasive techniques, the evolution from conventional surgery, maximal invasive, thoracoscopic, laparoscopic interventions, endoscopic percutaneous interventions, and seamless interventions, like happens with sometimes, radiotherapy was always seamless, so it burns a little bit of the skin, but also happened with the fact that you can use, shockwave lithotripsy and other events. So all these techniques coexist in 2015, and you need to choose which is best for the patient you are looking at. So these techniques are minimal trauma, local anesthesia, in ambulatory patients, short or non-existent convalescent period, and they are safe and cost-effective. They have replaced surgery for vascular strictures and occlusions, controlled bleeding. Nobody would like to operate today in a bleeding spleen alone. You can embolize it, it's not a problem. We do it routinely, tissue diagnosis for biopsy, drainage of collections, management of benign and malignant obstruction, biliary, urinary, etc. Palliative and curative. Let's put curative between quotation marks because you don't cure cancer, you control cancer, treatment of selected tumors. And in 1967, Alexander Margulis, in that seminal article where he named the specialty interventional radiology, said the patient must be followed carefully and responsibility must be assumed faithfully. And in 1987, 20 years later, Robert White, an angiographer, from the East Coast, says if the tools rather than the disease process becomes our major goal, we will lose credibility and may even suffer erosion of our specialty by non-radiology specialists interested more in the biology of the disease. And history proved that things went that way somewhat. In 2015, how we practice interventional radiology is very diverse. It changes, it locally changes from one place to the other. Depends on institutional needs and working relationships. Here we have a lot of people that do image-guided interventions. But that's the way it is, and service is what we need to do. Immediate service, gracious, educated, and professional. In 2003, this was very worrying because we have seen the decline. Actually, SIR now is a large society, but when they started, they were a little kind of people who wanted to say, well, we know how to do the things, people are going to come to us. Didn't happen. Okay, techniques can be learned and machines can be bought, and the companies will not care where you're coming from. In the meantime, you pay for the material, for the equipment and materials. So the strategic plan was to establish interventional radiology as a clinically based specialty with direct patient referrals. This in some places happens, and we do it here, a little bit as much as we can, okay? And the partnership with diagnostic radiology is at this point was more critical. Today, it is still critical, and I think will be critical always. But, the issue is at the point it was, especially in private practice, interventional radiologists were not really taken care of. They were kind of, for the group that did only diagnostic, they really did not like them because there was a lot of things they needed to read while they were doing procedures. So the growth and development depends on integration and synergism with other specialties, I think especially for complex things, complex procedures, and continuous search for new applications, techniques, and materials. In 1999, in Boston was the last meeting of the SMIT, Society of Minimally Invasive Therapy. It was a great thing. Started in 1989. 10 years lasted this society. The society formed by surgeons, by all the people that do minimally invasive or image-guided interventions. Of course, there were interventional radiologists too, but then dissolved because each specialty sucked in their representatives. So the president of that meeting, Steve Dawson, the one of the Dawson-Muller catheter, says sharing of technology and resources in a multidisciplinary fashion by minimally invasive specialties improves the practice of all, results in better patient care, and is cost effective. And this is sound and is great. The only thing is because I think that the market has not played to support this concept. However, this is still very valid. So the VITAL conference that you see here is a conference that we created in 1999, because we wanted to create a center here of that. And we worked with the dean at that time, some of the chairmen, the Dr. McDonald and Venable and so forth. Great enthusiasm, but we never implemented it. It was MIDA stands for Minimal Invasive Diagnosis and Therapy Center. And interventional radiology is a great specialty, great super specialty. Invented procedures for other specialties in 1973. And that's when SIR was founded. And we keep doing that. And research and innovation is what we need to continue doing. IR today, is the tip of the iceberg. I think that it's not, I don't know if it's going to be IR or whatever you want to call it. But these procedures are here to stay and will progress until we found like bones, remember on Star Trek, that can heal you without, through the skin with a little kind of microphone or something like that. Okay. That's for the thing. What I want you to do is, all of you that do interventional radiology, is really take full responsibility of the patient, okay? And your contact information should be the chief of the services, the clinical services. The chief resident and not the intern, but because with all respect, interns, are great, but they don't have any decision making. In preparation for tomorrow, I like to go over some things that are basic, and you will see repeated in the next one, but this is key, because without these tools, and Meghna, you're welcome to pitch in, it's very hard for you to do ultrasound, especially interventional ultrasound. One thing is to miss something when you're doing diagnostic ultrasound, which is important, but not damaging to the patient at that point. Another thing is trying to do something with ultrasound when you are doing something invasive. What you're going to see, we have given courses of ultrasound many times. This is in the early 90s, through the 90s, some in the year 2000. The last time I gave one was 2010. And so what you're going to see, the machines are a little passé, a little old. However, the principles are the same, So this is a presentation with a couple of additions at the end that is an introduction to use ultrasound. So the 7 steps: choose appropriate transducer exam type, enter patient ID, check transducer orientation, choose frequency, adjust depth, adjust gain and focus. And tomorrow, hopefully, we're going to do that in the simulation lab. So choose appropriate transducer for exam. There are different transducers. You see these transducers? This machine is a B&K. B&K is a company from the Netherlands that were the original people that used ultrasound for guidance. Holm, a urologist, was the guy that created the first needle guide to do nephrostomies. And what you see here in these transducers, and I have used them in the early 90s, they had on the transducer, this button is to activate is the freeze button. Now they come in, some of them new, but this has been existing for a long, long time. So electronic transducers have no moving parts. Most of the transducers you're going to see today, they are electronic. The mechanical transducers have crystals that rotate inside of the probe. This is simple, but whoever has not seen an ultrasound, when you see this linear transducer, which is many little emitting sound here, and this is a square with a flat line on top. This is a linear array transducer that fires sequentially. This is a convex array, which is goes a little deeper because it has a lesser frequency, usually for the abdomen, obstetrical. And phase array, which is when you need a little focus to get your transducer, and it can be cardiac, neuro, pediatric scanning. It's good for us for intercostal, okay, and you can see a heart here. So this is B&K, the company that announces these things. So they say here to choose the transducer, you have this way to do it. The one we use, GE, you need to disconnect them, and they're kind of different. The type of exam is important, and you know that you have presets about frequency and gain. Enter the patient ID, and start the exam. Check transducer orientation. This is key, especially for interventional. Transverse or axial, the right needs to be in the right, the left needs to be in the left. By convention, the right is on the left side of the screen, and the left is on the right side of the screen. And in sagittal, the head is on the right, and the feet are on the head is on the left, the feet are on the right. And this seems silly, but this is all you need to see if you are oriented or not. So you can remember that the mark in the transducer doesn't mean that you see in the right or the left. okay? Because in all machines, there is a button that you can change that, according with your needs. Choose the frequency. Remember, the frequency is in megahertz, and as much frequency goes up, penetrations goes down. You see less. You see more details, but go through less tissue. And of course, at that time, these transducers have variable, hey, how you doing? Variable frequency, and you could change it from the handle without touching anything else. And then the frequency, you can see at the frequency the difference in texture. And also the depth. The depth is where the ultrasound beam has the narrowest, the focal zone is the narrowest, so you have more detail. You know, this is too much depth, too little depth, appropriate depth. You see how you can see clearly. You have more resolution. The gain is the white, you know, this is too much gain, very white, too black, too little gain, correct gain level. This is important when you do a biopsy and everything to see the needle, you know, that helps you. Then the TGC, the time gain compensation curve, regulates the gain according with the depth you're in. So you can have a lot of more gain in the bottom if you want, or whatever. Today, the machine that we come, usually the TGC curve, all the markers are at the same level because they are coordinated, and then you can modify if you want. And the focal point is where you have the best resolution, and that should be there when you do the a biopsy, for instance. And that has to do when the delay in receiving the echoes back. This is the correct focus, and incorrect focus, you don't see the clarity. And that's about all. And this is some add-on. You know, it's just from the beginning, choose the right transducer for what you're going to image. High frequency transducer, 70 MHz, higher resolution, poor penetration. They are good for the neck, extremity, vessel, superficial ultrasound. You have seen this, but you need to repeat it. You need to be clear, you know, put in your brain. Low frequency transducers, 2.5 megahertz, lesser resolution and better tissue penetration. They are useful for adults, ultrasound in general. Obese patients require transducers with the lowest frequency. And check on that. Check on that. The other day we were doing an enormous man, and really, I mean, at the beginning we didn't see it very well, and at the end we couldn't. I mean, they got so fat. But anyway, you can, when you put a 2.5, for instance, megahertz, you can see a little more. Which is the lowest megahertz that we have now? 2 to 5? Align the transducer. By convention, on sagittal and longitudinal images, the head of the patient is on the left side of the ultrasound screen and the toes are on the right side of the ultrasound screen. And on axial, transverse, images, the right side of the patient on the left side of the ultrasound screen and the left side of the patient on the right side of the screen. I'm sorry to repeat this ad nauseum, but the worst thing you can do is just misplace the transducer and you looking at the others in another place in the wrong way what you want to look at. And in some tips for the ultrasound impaired, ultrasound friends, allow good penetration of ultrasound beam, a lean body, children. I'm referring to the young ones, not to the big, massive teenagers that we have. Fluid field structures, the gallbladder, urinary bladder. Ultrasound foes that prevent ultrasound beam to pass through, fat, air, gas, and calcium, biliary and urinary stones, the ribs, the bones. Those things do not let you go through. Okay? So that is for trying to do, then this is a B&K unit. You know, they usually have these colors and so forth. And this machine, similar to this, is one in the OR here. I started using one that was even a little older, but it was a great machine. And you can control everything from the transducer. You can take pictures also from the transducer. Any case. Any comments? Meghna, you going to say something?
So tomorrow when you do the simulation, you're going to do it with that jello and the olives? Is that what's...
What's that?
We have that. We have a full abdominal mannequin and then we have an upper abdominal mannequin, and then we have 2 arm mannequins with a tube inside for vascular, and then we have a CVL mannequin with IJ. So we have all those things, and then in addition to that, we're thinking about, or I'm going to put together this ultrasound medium with olives and kind of thing for needle localization.
That is yet to be made?
I'm not sure, actually. My wife is supposed to be trying to make it today, and I'm going to be making it later today. So.
Yeah, if she can't make it, don't worry, just get turkey breast. That's much easier than making
Turkey?
it.
Well, that's what, we were also discussing.
Yeah, we can do it on turkey breast, wrap it on with just wrap
Yeah.
it, and then put
But now I've got
Yeah,
all
let me tell you.
this Metamucil now.
No, but you know what happened? I mean, look, I have done this for many, many years. And I tell you one thing, it's very messy and disgusting. You splash all, and people have used turkey breast and everything. I've done it. The best thing, the best thing to do is to have, but what we used at the RSNA was a bag of barium, filled. In that case, you use agar, The one we used at UCSD was agar with thymol, and the one you have seen here in the picture. This is here. We made it here. But I think that anything that the problem with this thing is that if you can use it once time, like for instance the bag is to use one time, the bag with agar and everything, or gelatin. But if you use animals, I tell you because people have used that. The turkey breast is one of the most common and easier to use. The roast is another idea. But I mean, in my opinion, it really, what the objective of this is to see what you are doing. And the beauty of having something kind of transparent, your goal is not to hit it. The goal for you is to understand there's a moment in your life when you're using ultrasound that you can see the needle. And that moment is an epiphany, at least was for me. When I could see the needle with ultrasound, I said, this is wonderful. And because then when you see your target and you see your needle, this is a matter of you practicing and making it happen. When you are in the dark, like when you're doing ultrasound without training, and that is something that is, I think I don't like that. Honestly, I don't want all of you to start doing the thing without having a minimal basis of this. Also, most of you go through interventional radiology and do not know how to operate a machine. And part of it is because our techs don't want us to do that. Now they are a little more compliant about that. But you need to know how to use a fluoro unit. Tomorrow you're going to be in a place and you will be running the show. And you're not going to have too much help because the help is going to be doing something else for you and doesn't have time to take a picture or something like that. Okay? Also, if not, talk to the people that are in private practice or people that are in other universities. Hmm? So this is a simple thing that I used it for many years ago and everything, but familiarity with sonography, eye screen hand coordination requires understanding and practice. Needles are seen because they reflect and scatter the ultrasound beam. Needles need to align with or transect the ultrasound beam to be seen on sonography. Needle visualization is better when there is acoustic impedance difference between the needle and the tissue. These are principles that you need to know. Then regarding the model you want to use, you can use anything, but I think that I would not like to leave a mess of fat sprayed, on the place, If we are not ready for that, we do it another time. But I would like to be a little bit more acceptable about the whole thing. The needle tip has multiple facets and refracts and reflect the ultrasound beam the most. That is why we see the needle tip easier than the needle thing. So needles are better seen when there is a difference between the acoustic impedance of the tissue and the needle. Fluid is good, fat is bad. Patient body habitus to the needle. Can we see our target? Vessel or lesion with the ultrasound. Can we identify with ultrasound a safe pathway from the skin to the target? Target location is more important than size. adjacent to vessels of bowel. More than 7 centimeters deep is very hard to guide your needle directly to more than 7 centimeters. Transducer selection again, vascular, non-vascular target, anatomical location, transorificial, transrectal, transvaginal, needles, standard or needles with echogenic tip. High frequency transducer for vascular, non-vascular target, lesion anatomical location, neck, high frequency, thorax intercostal, more fluid preferred, abdomen, convex, array 2 to 5 megahertz, transorificial, transrectal, transvaginal, lesion depth, superficials, linear arrays, deep, more than 5 centimeters, convex arrays 2 to 5 megahertz. The selection, depends on what we're going to use it. I don't know why it's this. This is what you want to consider. Can we see the target? Can we identify ultrasound safe pathway from the skin to the target? Target location and depth. I don't know what it's doing this. Needles are better seen when there is a difference between. Oh, I'm going backwards here. Simulation lab with phantoms, ideal. Commercially available phantoms, homemade phantoms, ballistic gel, agar, gelatin, etc. Inexpensive. Supermarket phantoms, turkey breasts, watermelons, etc. Inexpensive but messy. I think if you don't have time, Justin, to do that, we can put it for another time.
I've got the material already. I'm going to try it. I think just to have a couple. If we do this again, maybe to have a couple of different things would make it interesting.
Yeah, let me tell you, I don't know if you've seen, but for instance, the phantom we used to have here, and Travis Henley made a few of them, looks like liver, and it's a good thing. But I tell you, I never worked really realistically with the turkey breast and everything because I thought that it were gross, honestly. You need to have gloves and everything. With the other phantoms, if you don't mind, that's okay. The Cro-Magnon, my Cro-Magnon ancestors are a little. Anyway, the technique of freehand or needle guide. This is the first needle guide that Holm described for nephrostomy, and this is the ultrasound from B&K that I used in the early 90s. We did a study with VX2 carcinoma in rabbits. Transplanting VX2 cancer, which is a squamous cell carcinoma that occurs in wild rabbits and is papilloma induced. It's exactly like the head and neck and cervical cancer. And these are the needle guides and different transducers. The insertion, ultrasound beam needs to be perpendicular to the sagittal plane of the needle shaft. You can see the whole needle, or perpendicular to the axial plane of the needle shaft. The only problem with this is you can go deeper and you can lose the thing. So here you can see, this is another of the phantoms here, Oops. What is it?
If he already bought the turkey, I told him to have his wife cook it and I'll eat it tomorrow for lunch.
Yeah, that's a better thing. Yeah. Well,
I hope you like olives. Stuff with olives on it.
Yeah, the olives. You can get the olives from the thing, and this is how you see it. But remember, this is good, but you can go deeper if you don't realize that. Keep the focal spot at the level of the lesion. Rock the transducer back and forth to find the needle, and once found, follow it to the target. If you don't see the needle, look at your hands. Sometimes you have the transducer here and your needle is here. You're never going to see it. You need to put it on the right thing. It's a simple thing. But, we have issues especially with the people that are very heavy. Jiggle the needle to detect tissue motion that will assist you in finding the needle tip. And may inject fluid or a wire to see where you are. When you're lost and you don't know where you are, you can inject fluid and you will see the fluid moving under ultrasound or a wire. Okay? Well, this is the same thing I've seen before. I have repeated ad nauseum, but I repeat these things because I see them happening. This is alignment, choose the right transducer, whatever. But this is, repetition is what you learn, okay? So that's it. I mean, we don't need to do anything more of this. So what, I think that properly understood and practiced principles of ultrasound-guided needle localization technique allow safe access for the performance of vascular and non-vascular diagnostic and therapeutic procedures. And this is Tom and Beckett, that even he can learn if he practices enough. Okay? Great. Well, I hope that you at least refresh a little bit what you do normally. But I think ultrasound is a great method. It's not sometimes appreciated as much, but here we use it a lot, and we think it's great.